most of us in this room have over the years have experienced barriers to frank two-way discussions with physicians treating us for neuroendocrine carcinoid or carcinoid syndrome. We're fortunate enough today to have with us a doctor and patient whose candid interaction and communication amplifies the way that we should be able to interact with our doctors. We all met Dr. Anthony in our opening discussion this morning, and now I'm pleased to introduce Jerry McDowell. And I will tell you that she wouldn't be here today if it wasn't for Dr. Anthony. And I have to tell you, there's a lot of patients out there that wouldn't be here today without Dr. Anthony. And I have to take a moment to say that many of you might not realize this, but I've had a long relationship with Dr. Anthony probably since 2005, right? Since 2005. And we are a community that is very tight. We are a family. And you'll feel that along the way. A lot of patients, when they go to see an oncologist, after 5 years, either you're released or you're gone. These doctors are with us for lifetimes. And so you actually form that bond that you cannot have with anybody else. And we are so blessed that we have doctors that care about us. And so Dr. Anthony is one of those that is a true treasure to our community. So, Jerry, can you tell us a little bit about your pre-Dr. Anthony years?
Okay. It took 7 years, like Mary Ann. It took 7 years to get a diagnosis for me. And I was diagnosed with a tumor in my small intestine and had surgery. And then I did well for 5 years, and then I started having symptoms again. And so I was sent to another clinic out of town, and they said that it had metastasized to the liver and that there really wasn't any treatment or any cure, and they just kind of patted me on the back and sent me home, and they said to find an oncologist to follow me. So I went through like 4 oncologists that really didn't know anything anymore about neuroendocrine cancer than I did, but finally ended up at Marquis Cancer Center, and Dr. DeSimone was there, and he was telling me that we were getting a specialist coming in. That would be Dr. Anthony. So I was real excited about that. So,
well, many of us travel thousands of miles to find the doctors, and after 7 years getting the wrong answers and little or no hope, we're very fortunate to have a smile on Jerry's face and Dr. Anthony joining the Cancer Center here in 2011. Dr. Anthony, do you recall when you first met Jerry? How did you find her health? And even more important, how did you find her understanding of what the family expectation should be regarding her future?
Well, I think the first time I met her was actually at a support group that had been going on at the Marquis Cancer Center. So I think I'd been invited to come and talk to the support group within the first few months of working there. And when I actually saw her as a patient would have probably been a year or so later. Now she was getting the monthly injections of somatostatin, and over the course of several months started noticing fluid in the legs. And at that point, her care became a lot more complicated. So we went down a very tenuous path as we looked and tried to help her in understanding what this fluid collection was in her legs, that it was carcinoid heart disease, and how we can go about fixing that and improving the function of her heart. So that work spanned probably about a year to 2 years before we got her through the surgery, through the complications of what she faced after surgery, and then got her back in about June of 2015 back to where she could start having an independent life with less and less dependence on oxygen. So the times that I've seen her would be at about the lowest that you could see someone in the hospital, difficulty breathing, can barely raise their head off the bed. So
And
it's,
every time I opened my eyes, he was there.
so she really had us worried. She did undergo tricuspid valve replacement in August of 2014. And when this decision is made, there's a lot of thought that goes into this. And we don't go put someone through this type of surgery without thinking that they're going to have years to benefit from it, not just a few months. And during her post-op recovery time was when it got really bumpy and shaky for us. And I was so thankful that as she did recover, we had enough time to start measures to not only continue the somatostatin analog, but also to do other things using talotrostat. She went in on the study, and she got on the real drug during the 90-day, thankfully. We couldn't influence that, but were so beneficial to see that as the talotrostat was being used, about 3 months after that, 2 to 3 months after that, is when she really turned around. And to this day, I can't find another reason of why her case turned around. And I don't want to put her forward as to say that everyone's going to be like Jerry McDowell. But I've sort of presented her case at national meetings with cardiac specialists, with other medical oncologists, and we can't really come up with another easy solution of why she turned around as she did. And we're so thankful because now I hear these wonderful stories about how she can get in her car and drive to Indianapolis and visit her grandson. And these are just wonderful, wonderful stories where her family doesn't keep her on the leash, you know. And you know, as you get to know folks, you know, you understand their struggles that we all face. And as she was going through this, Tom McDowell, her husband, was caring for her as any devoted spouse would. And as her health recovered, she had to start taking care of him. And so I just thought it was such a wonderful story that we've got her back to where she can function and have a very meaningful and productive life.
So, Jerry, what about you? How do you recall your first visit with Dr. Anthony, and how did you feel?
I was really excited and hopeful because I knew of him and that he was a specialist for neuroendocrine cancer. And I could tell that he was really listening to me and that he was not only caring for my physical well-being, but also for my entire well-being. And he was very compassionate, very passionate about what he does. And I knew I was in the right place. And I'm just very blessed.
That's good. Okay, now your disease, has it been relatively stable for the last 7 years, or?
It has been, yes. Not the 7 years because I had the tricuspid replaced in August of 2014. And it took a couple of years to get fully back with my strength and everything, but I'm doing well, pleased.
That's good to hear.
I'm doing well, thank you.
Okay, so now those of us who have lived with the disease for a number of years understand that medication usually, standostatin, octreotide, lanreotide, somatulin, and surgery are the foundations of our being able to experience the best possible day-to-day health and the best quality of life. But some of us tackle some other unwelcome aspects of the disease, like carcinoid syndrome. And I could say I am full-blown carcinoid syndrome 24/7. I was on standostatin, and I was on 120 milligrams a month for over 8 years trying to get my serotonin levels and my bathroom trips and everything else. And I just started on Zomela myself, and the difference is amazing. But we all deal with the flushing and the diarrhea. And also patients say that they're lost for words, and it's hard to explain to people and how to explain to your family that you can't leave the house because of the diarrhea episodes and everything else. And what kind of toll does that take on the families?
Well, I was to the point where I just didn't even plan to leave the house in the mornings because I knew I couldn't do it. And I would decline social invitations because I didn't want to go and have to excuse myself 2 or 3 times while we were out in a social situation. But then after I started the Zermello also, it's really changed my life as far as not having to worry about where the bathroom is. And as a matter of fact, I used to play golf, and it was like, I don't know if I can play golf today because the bathrooms are few and far between on a golf course.
And most people with carcinoid syndrome, the first thing you do is you walk into a store, and I bet you, if I asked anybody in this room, they know where every bathroom is in Walmart, Kmart, Target, grocery store, every fast food restaurant along your route to work and on your way back. Because I know I do. That's the first thing I do. I walk into a place, Robert will tell you that's the first thing I do. Okay, where's the bathroom? I have to say I'm a little disappointed because I asked them for a bathroom close by and there isn't one. So, Dr. Anthony, can you share some of your experiences with treating patients with carcinoid syndrome? And how do you find the patients speaking? Are they comfortable talking about the diarrhea? That's one thing that we also have to say is that, you know, you really need to tell your doctors everything, because the slightest little thing that you think is not important can be a really big thing. And I'll give you an example. I have lupus, so I run fevers at night. I started running fevers during the day, which I thought were fevers, actually turned out to be flushing. For several years, I never told my doctor about them because I just assumed it was related to the lupus. Had I said to my doctor I was flushing or tell him that maybe I was running the fevers during the day, I might have been diagnosed earlier. So it might not seem important, but you need to tell them. And you need to keep a diary of when you go into the bathroom and stuff like that, because we all have a tendency when that doctor walks in the room, the doctor says, okay, how are you feeling? I bet you 90% of you say, fine. So how many times are you going to the bathroom? Not much. Because you don't think about the 3 weeks earlier, you're thinking about the last 24 hours. And you need to make sure that you tell your doctor what happened during that 3 weeks, not what happened in the last 24 hours. So do you find that happens with your patients?
Well, we have sort of ways that we inquire about it. I think what the difference in a center that sees a lot of neuroendocrine tumor patients as opposed to, I'm going to say, just a medical oncology practice that's attempting to deliver standard of care across the different tumor types, is the symptoms are looked at as the pivotal symptoms, not symptoms that are on the sidetrack. They're in the center stage. So when someone comes in, we're going to want to know and focus specifically on what their weight's doing, what's their energy level, what's their performance, where in life are they not making it, are they looking for too many bathrooms, and so the discussion in terms of stool frequency and things is critical. It's not so much that we focus on just the last few days or such, but we really want to get a sense of, is the regimen that we're working on right now, is that regimen satisfactory or not? And if it's not, what can we do to improve it? Some of the things that we have to teach people is that when we give you the somatostatin analogs, we're replacing one kind of diarrhea for another type of stool changes, and that is steatorrhea. So if our patients are not experiencing some degree of floating stools, we sort of wonder, is the somatostatin working or not? So we want people to know what's happening to their bodies so that when this happens to them, they're not wondering, why is that? Is that something abnormal? So I think our discussions are really related to what do you expect from the disease? What are we seeing from the drug? And let's not be treating the steatorrhea with the drug by increasing the dose of the drug that's causing it. That makes no sense. So we have ways of ferreting that out and attempting to appreciate that more so than probably a center that is just doesn't get down into the weeds, I guess is the best way of looking at it. If you're not down in the weeds and understanding each one of these critical symptoms, then I think communication and things is not as good as it should be.
So Jerry, how did the carcinoid syndrome impact your day-to-day life?
Well, like I said, it was very difficult to make plans for anything, and a lot of times you make plans, and I'm sure you all know that you make plans and you have to cancel them because you never know from one day to the next how you're going to be feeling on any given time. So it
Now-
is very difficult to.
Besides the effect that it has on your family, what about how did your friends react? Were they understanding or were they confused?
My friends are very understanding. I have a really good support system from Marquis, through my friends, my church, my family. I'm just very blessed that I have so many people that support me and they understand, and they're just wonderful with it.
That's great. Now, how comfortable did you feel when you went to see Dr. Anthony? Were you comfortable talking about the diarrhea or the flushing or the symptoms or, just in general?
I was comfortable, and I would be the last person in the world that would think I could ever go in and say, yeah, I've got terrible diarrhea. But I'm very comfortable because now it's just a matter of fact. It's just part of the medical process, and I've started to say that babies and carcinoid patients are so much alike because I've got a little 10-month-old grandbaby, and our bodily functions is everybody's business. So we're a lot alike in that way with our babies.
So, Dr. Anthony, you talked this morning about being an investigator on the clinical trial. We have Jerry's permission to share about the trial and stuff like that. You touched on it a little bit. Is there anything else that you would like to add to that?
Well, I would just sort of like to state that a clinical trial is responsible, at least we're giving it credit, for Jerry being here today. If it wasn't for a clinical trial, she would have to have waited till March the 1st of 2017 to have started a drug that she started in 2015, so 2 years earlier. So a clinical trial made that big of a difference. When someone goes on a clinical trial, there's a lot of anxiety. There's anxiety on the investigators, on the physician side. There's anxiety on the patient, anxiety on the nursing, the support structure, because we don't know in advance what's going to happen. We're walking down, we're in an unknown, uncharted territory. And when someone does enroll in a clinical trial, it's sort of, the way I look at it is you've just been moved into first class of an airline. You're somebody now that is volunteering your time, that are taking risk, and in return, you're going to get a lot of attention. The clinical trial is going to require things that are going to be done that would normally be done under standard of care. So you're going to learn about yourself in a different way. And the other flip side is that when you have something happen to you, you have a number to call. And I'd like to kind of give a shout out right now to Cynthia Leadham back in the corner there. Is a blue sweater she's wearing. Cynthia was the clinical research associate on this trial. And I can tell you, anything that happened to her, the best patient advocate for her was that lady sitting in the back. That lady knew everything that happened, and she put her case in front of me, in front of other providers, to become her champion, become her advocate. She went with me to have her case discussed at the cardiology review board because this was a complicated cardiac case, and she followed up in every aspect and communicated with the sponsor and let the sponsor know at all times what was going on. And that's just as hard. Communication now, when we do clinical trials, does bring in another dimension of a sponsor. And a sponsor has the rights too. The patient has the rights that are outlined in that consent form, but the sponsor can withdraw their support. The sponsor has their own set of rules that they can go by. So if we're not doing our part, if we're not filling out their forms and submitting the data, they can choose to terminate a site. So it's people like Cynthia Leadham who are dedicated to do this work for us, and I can't say enough about her because as our process went through an FDA review, we had an FDA agent with us for 5 solid days, set with all our records, and Cynthia's the one that we really left with no significant deficiencies. So thank you, Cynthia.
Thank you, Cynthia. You were such a big help to me, too. She was my clinical trial coordinator, and she was there for everything. She met me at the door every time I went into clinic. I had way more care than I would have had I not been on this clinical trial. But she was just absolutely on top of everything. And she's been to my home. She came to my home one day to pick something up and a big snow on. And she's just been wonderful. So I appreciate her so much.
Dr. Anthony, I just want to ask, just so patients understand, there's different clinical trials out there. What is their right as a patient? Do they have a right that if they start a clinical trial, do they have a right to say, I want to stop the clinical trial? Because I think there's a lot of misconception that patients, once they start on a clinical trial, they have no rights to say, I no longer want to take this drug or participate.
So within the consent form will have certain questions that will be put there and answered. And one of those questions will be, what is your right to continue in a clinical trial? And it will state that you can withdraw at any time. So in the world of doing clinical trials, we think of it sort of in 3 different aspects when we look to trial termination. The person themselves, the participant themselves can say, I'm done. No questions asked. No questions asked. We simply ask them, will you come back in X amount of time for the final checkout visit? And during that time, it's just, and they don't necessarily all do that. And what we ask them, they don't, it's not an absolute requirement. The other part is the physician, the investigator can say, I don't think it's in your best interest to continue. And if they feel like that something's not right, this trial is putting the person at risk, they're obligated to say, I think we should stop. And then the sponsor can come along and say, hey, guess what? Our situation's changed. We're out of money. I mean, I'm just giving examples. We have no more money to fund this. Or they can say, we've decided not to pursue this indication anymore, therefore we're not going to continue after, they may make a commitment saying your existing patients will continue to be treated, and then they'll draw a line in the sand. We had one company say, we're tired of working with an intermediary company. They call these contract resource organizations. Our CRO is driving us nuts. We have to fire them. Only way we can fire them is to terminate your trial. There are so many circumstances that could arise that the sponsor can walk out. So many circumstances the investigator can say, hey, maybe we should stop. Or the person says, I got in over my head. I really can't do this. So it's not like signing up for the Army or the military where you're going to be court-martialed.
Well, that's good to know. Jerry, I know that you were quite ill for the months before the trial. Is that something you feel comfortable sharing? If you're not comfortable, we totally understand.
No, that's fine. It was the most traumatic part of all was, of course, the carcinoid heart disease and the surgery that followed that to replace the tricuspid valve. And the surgery actually went well, and then I had started having complications. And I was in the hospital a total of 34 days, in and out a day or so, and then I'd be right back in there. But I was so well taken care of, and I have to say the continuity of care with my oncologist, my pulmonologist, my cardiologist, I mean, it was just amazing that they were all working together, and anything that happened, each one of them knew immediately. So I think that's the advantage of going to a multidisciplinary clinic like this, that you just have that in-depth care that I don't think you could get going from one place to the other. But as a matter of fact, they really didn't think I was going to live through it, and this is a joke. My husband went and bought cemetery property. And so anyway, we came back. I got out, and I said, ye have little faith. So, but I've been doing really well since then, and I just owe it all to Dr. Anthony, my faith, and UK and Markey Cancer Center.
That's
I
great.
really do.
That's great. And that's really important for you people to understand, that you really need to make sure that you have a multidisciplinary team and that you have a specialist to work with. You could see a local doctor, but have somebody that keeps in touch. I know that Dr. Anthony works with a lot of local doctors as well as some of the other specialists, because they cannot take care of all of us, but they do work with the local doctors, and it's important that everybody knows what's going on, because that's how you're going to get the best care possible. So, Dr. Anthony, if there's one thing we know about this disease, is that no one treatment is right for everybody, that no one person has the same disease. We are fortunate that you are passionate about the research as you have been treating your patients. Can you share any information about clinical research you're presently engaging on to help offer the zebras hope for the future?
So Dr. Shahan covered quite a bit of that this morning. Most of the trials that we're interested in are what we would say have been vetted extensively by other professionals in the field. Our phosphoridobulin everolimus trial was taken before our medical oncology group at NANETS, which is the North American Neuroendocrine Tumor Society, in Austin in September of 2015. Was when the trial was, we looked at all the data that came in on phosphoridobulin. We said, what's next? And the group collectively, from people from Stanford, from Dana-Farber and MD Anderson, we thought that combining it with the standard of care of Afinitor everolimus would be the next step. Well, guess what? The sponsor said, we're going after ovarian cancer. You guys in neuroendocrine are on your own. And so when I saw that, I said, "This is really." He threw the glove down, okay. And by golly, this was going to be a challenge. It's going to take a lot of effort. We've got to get our own IND, which means that we have to write the protocol. We have to file with the FDA. We have to run under FDA reporting guidelines, and then we had to go out and get funding. And I had a person in the Grateful Patient program at UK. Came forward and said, how much do you need? And made it happen. We also took our protocol through some competition among the Markey. The Markey has incentives for investigators to do this kind of work. And so we ended up having several different support structures. So when we do have this, I'm going to call it largesse, when something is handed to us, we want to look and see how can we best utilize those resources. So we're really quite pleased to have what we consider institutional commitment when we've been able to land financial support. Because having someone like Cynthia Leadham and having all the people that you need to report on an IND, there has to be some sort of financial responsibility, because the institution puts every charge in some sort of basket. Something, we do this, then something's got to pay for that effort. So we're fortunate to have that sort of infrastructure, that we can think of new things at the Markey. We can push the edge where our pharma partners can only do so much. Our pharma partners will focus on their one product. Us outside of pharma can look back and see a bigger overview and say, well, that one product may be good, but we got to make it better. We have to use something. We have to come up with some better thing. So we have that trial. We have the DLL3 trial, the rovalpatuzumab for the higher grade, the more aggressive tumors. We're opening the PD-1, the immunotherapy, the checkpoint inhibitor trial. That should be opening in the next few weeks. This is a Novartis trial. And so those are the three major ones, and we'll follow that with some other ones as these other ones mature.
So overall, we have hope in that there's going to be new treatments coming along.
There's absolutely no question that there's going to be new treatments coming along. We've just gotten Zermello in February. We'll have the PRT, the Lutathera drug, sometime first quarter next year, probably as standard of care. Now it's on compassionate or expanded access basis in the selected centers across the U.S. What's going to happen after that? We'll have to wait and see. sort of step at a time. But most of my colleagues with the experience that I've had when we talk about what the next step is, I think for some subgroup of neuroendocrine tumors, immunotherapy is probably going to be that next big breakthrough. It's not for everybody, but for some selected subgroup, we think that's probably going to be a success story.
Well, I thank you both for joining us and appreciate it. We're going to just